Good morning, everyone. It's a pleasure to be here, and it's my pleasure to introduce Ilgi, who doesn't need introduction, of course. And I'd like to say that she defines herself as a dreamer. And her dream brings us all of this wonderful meeting. And thank you to be part of your dream. Talking about the speech of today, work with children with developmental disabilities without enrolled families is incomplete, sometimes causes harm, and can lead us to misunderstanding child needs. And as using a word of a very famous and outstanding pediatrician, no child is an island, as Maurice Green said once. And we need to understand better the ecology where this child lives, because this makes us to really understand the child needs and also family needs. Ilgi, please enlighten us.
Thank you very much. Thank you, Ricardo, Heidi, to the organizing committee. I'm going to be sharing with you today this topic of partnerships in practice, essentials of family-centered care. So what I would like to be doing is just to give you a brief history of family-centered care, essentials of family-centered care, using examples of research, some video demonstrations and case stories, and then to leave us with some recommendations that we can think about. So coming to history, I found some photos, and the ones on the left, the top and the bottom, are of l'Hôpital d'Enfants in Paris. And you can see that in the top left, we have parents waiting outside the hospital for visiting hours. At the bottom, we see a child in the center, and we see the doctors and the nurses around the child. I don't see any parents there, but the child seems to be in the so-called center of this photo. The ones on the right are from Şişli Etfal Hospital in Istanbul, which is along with the one in Paris, is one of the first children's hospitals in Europe. It dates to 1700s. And as you can see, children are hospitalized without parents, and in the bottom, a child is undergoing some sort of procedure, and there doesn't seem to be a parent around, many doctors there. How did family-centered care begin to be talked about? We owe this to some pioneers. And one of them was René Spitz, where he did some observations of children who were orphaned and hospitalized with no parent coming in. And we have a historical video here that I can share. And you see how he noted how this child was just in such distress. These children were withering away, basically. Later, after the Second World War, a pediatrician named Robertson made these tapes, actually. This is coming from his own tapes that he made of children hospitalized without parents in the hospital, and showing their distress, and how later on, as time went, these children were actually showing signs of this distress even when they were reunited with their parents. So these two people actually, I think, are pioneers in helping pediatrics think about family-centered care. The child that is left without the parents, and James Robertson. My own story begins when I started noticing this. It's very interesting that I didn't take note that there was not family-centered care when I was doing my residency in Istanbul. We did have mothers there with their children, but fathers could not enter the ward, and I was one of the people policing, no, you cannot come in, forget about the things that we do now for family-centered care. They weren't even allowed to be there with their children. So, but then after developmental pediatrics training, which I think is a magical training, when I came back, I noticed that I only wanted to go back to a hospital where parents were allowed to be with their children. But there were so many, so there was one in Ankara, which is where I went, and all the rest, parents were just like the one in Paris, waiting outside, sometimes sleeping outside the hospital in the garden. So I looked into this and wrote a paper actually of why, the reasons of the parentless child in the hospital. I think we owe family-centered care to some unbelievable theoreticians, Bronfenbrenner, Winnicott, Bowlby with attachment theory, Daniel Stern with his voice of the motherhood constellation, and the American Academy of Pediatrics, who has really taken this on and has over years made us available some guidelines on what family-centered care is, how it can be provided, one after the other. And now we have materials. If you Google family-centered care, there is so much on the websites of what it is, how it can be delivered. There's an Institute for Patient and Family-Centered Care. There is a National Center for Family Professional Partnerships. There are materials. There are self-evaluation tools, provider tool, family tool, user's guide. There's quite a bit. And there is research on it. So if we look at 2017, even in the last 3 months, you can see so much published on family-centered care. However, some leaders in this, one of them is Dennis Kuo, wrote recently that there is some explanation needed in family-centered care. So I quote, family-centered care is at a crossroads today. Fundamental misunderstandings persist about what it is, how to implement it, and how to determine the family-centeredness of care. Family-centered care cannot deliver on its promises unless greater understanding and support for family-centered care are achieved by healthcare providers. So this is the purpose of this sharing, that we in IDPA talk about family-centered care and understand it in different ways and share this together. So how is it defined? The Committee on Hospital Care and Institute for Patient and Family-Centered Care of the Academy has defined it as being grounded in collaboration among children, families, physicians, nurses, and other professionals for clinical care, planning, delivery, and evaluation of healthcare, education of healthcare professionals, and research. So it is grounded in collaboration. What are the essentials? I'm going to go over 6 essentials with examples. So the first one is listening to and respecting each child and his or her family. So I think this one overrides everything and is a part of everything, and we understand it very clearly. So I think I'm going to skip this one, but come to sharing of information, and that is defined as sharing complete, honest, unbiased information. This includes talking about the diagnosis, providing verbal and written information, enabling access to continuous information, conducting family-centered rounds, which are, I see in the research now, a hot topic that is emerging. So where are we in this? I think this is an area that we need to constantly improve ourselves. Talking about the diagnosis, in the GMCD course 2 days ago, we were wondering whether and how we can talk about a diagnosis of autism, for example, whether it should be in the first meeting or the second meeting. So this, the talking about a diagnosis, and that could be leukemia, it could be any other diagnosis, this needs work for us. And research on family-centered care has shown that we are okay about we are not okay about sharing information. We are okay about some other things. So there is an instrument called the IDPAC. Some of you will be familiar with this, the measure of processes of care. And the authors of IDPAC, so Rosenbaum and colleagues, reviewed 55 studies from 11 countries and 14 languages, so low and middle income countries are included. And this showed that families said service providers do quite a good job of providing respectful, comprehensive services in partnership with families, but there remain major limitations in the provision of general information. So I think one of the things we can do is go back and see how we ourselves are doing this. There is literature that came out after this review from Israel and Jordan, which points to the same thing. The third key principle is collaboration, collaborating with patients and families at all levels of healthcare. So clinical care, and you see in these photos the clinical care of triplets in the middle with a father and a mother, so collaborating with them. Professional education, policy making, program development, implementation, and evaluation. Healthcare facility design. On the left, we see families being consulted in the making of the model of the plan of the hospital, the architectural plan of the hospital. Healthcare facility design, research, and advocacy. And on the right hand, we see a plan for a birthday together with a family in an intensive care unit. So collaboration is essential. Research has shown that due to power imbalances, families and values and preferences may not be integrated into decisions. A systematic approach, therefore, to identify parental preferences and needs for decisional roles is needed. So what does this mean? I think it means that even when we say we are collaborating, there still exist power imbalances. The power being more on the side of the professional rather than the family, and this may lead to collaboration gaps. And so we must systematically evaluate how we are collaborating, what are we doing to collaborate, and to abolish this power difference. There is an amazing study which I wanted to share with you, which recently came out in 2017. So this comes from, it's called Is It My Turn to Speak? An analysis of the dialogue in the Family Physician Intensive Care Unit Conference. So this research was conducted by intensivists, so imagine. And what they did was they recorded 39 family conferences analyzed using an interaction analysis system. A turn they defined as a block of uninterrupted statements. So the healthcare-centered turn was 207 versus families took only 28 turns. So imagine how the discrepancy here. The turn density, the number of statements made by turn. So it's my turn and I've made many statements, right? So what families and healthcare providers were providing, so healthcare providers were putting 6 statements versus 2 statements per family. And many turns were between healthcare provider members, the dialogue excluding the family. Then they analyzed the reading level of the turn and found that the healthcare provider reading level of what they were speaking about was 9th grade versus a 5th grade level in the family. So collaboration is not easy. Even when, this was a research situation, people knew that this research was being done. So collaboration is not easy. But it can be done, and can it be taught? So I think the earlier we start, it's just like early childhood. The earlier we start, and if we're talking about physicians, the earlier we start in their medical school training, the better. So we have programs at Ankara University to actually help students work with families very early on, from their first year, so that they can recognize the role of families before the hierarchy has been built. I just want to show you a video of our residents who work in the developmental pediatrics rotation with us, and you can just see this is the resident passing the baby to the mother in good respect for the baby and the mother, and then we will see a resident conducting an assessment, but it's quite chaotic in there. The mother is there with twins, and then the brother is there, the father is there, but he is listening with good patience. Sorry. So the resident is at the back. And here are the twins. The resident is the one with the tie, sitting across. Listening. Listening, watching, just being there with the family. And enjoying the children with the family. Here's the resident post-call. You can see she's post-call. So she is explaining to the family what a good job they're doing with the family, how they're helping the child develop. She's not nearly sleeping there, but she's at it. So can it be practiced, the collaboration? Can it be taught? I think yes, but we have to start very, very early. The 4th principle is a strengths-based approach. So recognizing and building on the strengths of individual children and families and empowering them to discover their own strengths. And here, I will give an example with a story. So a 3-year-old child with autism spectrum disorder, the father sent an urgent WhatsApp message to the pediatrician asking for help. This is a family that doesn't send these kinds of messages, but they did. Mother took the child for vacation to grandparents. Child is uncontrollable at separation. On the plane, nobody could do anything because this child was frantically screaming. And in the grandparents' home, it's continuing. And the question to the pediatrician, should they come straight back? So what is the approach? If it's a strengths-based approach, what is the approach? Should we answer the family or should we ask the family? What are your thoughts? Ask, right? I'm hearing ask. And so what should we ask? That's the big question, right? What are we going to ask? And so I just put some points that help me. And I'm sure all of you have very helpful points that you use yourselves and that you convey to others. So for me, the question should not be deficit-based. So it cannot be about the severity of what's going on, of the uncontrollable behavior, not about whether the child is regressing, not about they've already told me, right? The child is screaming and uncontrollable. So what is the strengths-based question? I look for it. What is the question? So it has to be respecting their vision, trusting their strength and wisdom, knowing they are informed already, knowing their capacity to make the best of every situation until that one, right? So the question that I found for them was, what's the reason for going? Why did the mother take this child there anyway? So she had something in mind. She wanted to do something. And we have to learn this. And the father says to make use of nature, because nature is just beautiful there on the Black Sea coast. And so I said, well, let's make use of nature. Can we do that? And the father says, are you sure? I said, well, if that's what she went for, does she want to give this a try? And we said, shall we try and see? And so here's the next day. They're taking a walk in nature, and the child is fine. And the child is actually loving it, as we see in this video. And this is the most... This is the most actually that he's verbalized ever. So he really started verbalizing during this trip and after. So there was something that she thought was wonderful in taking him into nature. And so as long as we don't block this strength that's there, there is more of a chance that it will work. Support. Ensuring formal and informal continuous support to family and developmentally appropriate support to the child. What does support mean? So I have another story. I'm sure there are many stories in this room, but this is the story of a resident. This is not the family we're talking about, but this is the pediatrician I'm talking about in the photo. So when she was a first-year resident, there was a grandmother from the village taking care of hospitalized grandson in the intensive care unit. Pediatric resident sees grandmother crying, asks why. The grandmother says, in my village, when we want a child to get better, we wash her at the intersection of 3 roads. I am not able to do this here. If only I could. And the pediatric resident says, can you wait until I'm on call tonight? We can't do it now, but can you wait until the evening when my professors are away? And that night, together, they bathed the child at the intersection of 3 corridors in front of the ICU. And of course, not because of this, but the child does get better, and the grandmother crowns the resident with a kiss. So support can come in many different ways. Yes, it's a big clap for her. She's now an amazing pediatrician as well. So flexibility. Ensuring flexibility in policies, procedures, practices tailored to the needs, beliefs, and cultural values of the child and the family. So I have another story, and that is of another pediatric fellow this time. So we're getting higher up in our training. This is a pediatric fellow, Hematology, Oncology. There is a conservative Jewish family in the United States. The father is a rabbi. They're observing everything of Judaism. The child has acute leukemia. Pediatrician is Turkish. His name means Mohammed. It's not spelled that, but the family, of course, knows that his name means Mohammed. And the family observes Shabbat. For 3 years, Mohammed makes sure that all is taken care of before sundown on Friday so that the child and the family can go home. Otherwise, they will not ride a car, so they will not go home. He's seen this family once. He didn't know about this. He saw the family once the dad was carrying the child on his back, walking home, and never was this happening again. So flexibility. And in saying goodbye at the final bone marrow when the child was cured, the family gave Mohammed a calligraphy of the physician's prayer made by the father, and this is the calligraphy. So flexibility comes in very different forms as well. Now, family-centered care in low and middle-income countries. In our countries, are we doing research on family-centered care? These were the principles. We conducted one research, which we are repeating now after 12 years to see if it's changed, but we saw that we were in deep trouble. So these were families of children with special needs. It was a resident thesis. The numbers are small, but we saw that providing information to families, the families rated, 62% of families rated this as sufficient, but look at informing family of community resources, only 2% rated this as sufficient. So what they were understanding of information is not so clear. Asking about how families feel, only 19%. So there were other items here which I won't go over, but not many were above 20%. When we look at the literature, is there research being published from low and middle income countries on family-centered care? And there is actually, and I was really surprised and really happy to see that even in 2016-17, there were some papers that had been published from our countries. One is from India, 2 are from Iran, and 1 is from China. You can check these out and see that they are mostly coming from the NICU. So it's just like when in the United States, a big movement was to bring family-centered care into the NICU. And I think this is where we are seeing the progress now in the NICUs. But where is it in developmental pediatrics? In the services that are provided within the populations of children that we serve for. There are abstracts at IDPAC. And I bring an example here by Dr. Srinivasan. She found that waiting time for individualized services was an important factor that families rated in delivering family-centered care. There was limited access to information, and families identified support for stigma as one of their needs that clinicians should address. So I think it would be good for all of us to check out the posters and the oral presentations for what more there is on family-centered care, and to make this one of our priorities to bring research to next IDPA on this concept. Now, what are some recommendations to move forward? So I was thinking that I would share this quote of one of the fathers I work with you. He said to me, you know what, there's something called, in my mind, the megalomania of the normal. And this made me think and think and think, and I think that this is something that we need to reflect on. Maybe not to say much now, but just to think of it, that Families, how many of them are experiencing this? And what can we do to understand this and to help change this? There are barriers, and there are many, but so are our strengths. If a physician is seeing, a pediatrician is seeing 100 patients a day, which our pediatricians are, how are they going to provide family-centered care? I share with the students this piece because this is something that bothers everyone, the time limitation. If it shines through your eyes, families catch it. You know, in a second, if the humility, the humbleness is there, and the willingness to partner is there, families grab at this, and they grab at the pediatrician as well. It feels good. So when you provide it, it really feels good. It feels, some students say, this is why I went into medical school, to have relationships with people. And so it's a selection that we made, and maybe it will bring us back to this, to our choice of why we did this, and it feels good. So we need to not do it alone. If we partner with our colleagues, it's much easier to do, because then you don't stand out and you are doing it together. And I think I want to say, let's support IDPA. This has been a core principle of IDPA. It's written in the mission that family-centered care is written in the mission. Our first keynote speaker ever was Peter Rosenbaum, who has devoted his life to this, I think. So I think let's support each other to do better at this. Let's model and advocate for family-centered care around the world, and persist, persist, persist. Now, I will slowly end with an ultimate dimension of family-centered care. And so we went through listening, respecting, ensuring flexibility, sharing information, providing support, collaborating, recognizing and building on the strengths. But I think there is an ultimate dimension, and what I've called it is being family and having a family. I don't know if you would just think for a moment of when you felt like family with your patients, and you felt as if your family was expanding and that you had a family there with them. So there are those moments, and I just want to share with you a story of one of those moments to end with the ultimate dimension of family-centered care. And here I have a photo of someone you might recognize. He's in this room. He was much younger then. No less handsome Brian. But so this is not the story. This is not the family in the story. This is a different family. It's just for the picture, but it's a story of this pediatrician who has. I love the way Jean-Paul. Where is Jean-Paul? Is he around here somewhere? He's here. Hello, Jean-Paul. He said yesterday in his presentation, he said for Bob Needleman and Judy Palfrey, they made who I am. So I'm going to say, as a pediatrician, I turn to my mentor and say, he really made the way I am. There were many, and some of them are in this room, and I've said this before in Istanbul. But so I'll just share this ultimate dimension with you in this story. So this is a family from Puerto Rico living in the US. The child with HIV/AIDS at home in terminal condition. The pediatrician is informed that the child is worse and goes to the home, sits by the mother's side as the child dies, and then continues to sit with her silently as she holds his body, and she's unable to let go for hours. After about an hour, Mother gives child to him, saying, "You carry him down." He carries his patient in his arms, places him in the waiting ambulance. So this is our story. And I'm going to have a video after this, but I end with gratitude to all the families and children that give us a chance and the opportunity and the privilege to be their family.